working from in to out, we work from out to in, so to speak, and we can drill some of this joint away, find the nerve root, lift it up, and then work underneath the nerve root to scrape that bump away. Now, it's actually not that scary, but it's a little bit more challenging at this level than to do it at the upper levels where the joints aren't as broad and they're easy. It's easier to lift the nerve root up and get underneath it. Now, that doesn't mean it can't be done.
You also have to go deeper. Because with the other ones, they're on the outside, and mine's on the inside.
Well, so it's a little bit harder to treat this type of disc herniation, and the results of the surgery aren't necessarily as reliable as are the results for the more standard type of disc herniation inside the spinal canal.
Great.
Okay, so, and the reason, number one, is we've got this very sensitive structure called the dorsal root ganglia that gets manipulated at the time of surgery, and it can stir up the pain a little bit, and that's a problem. So where we say there's a 90% chance of a microdiscectomy helping a patient with a standard posterolateral disc herniation, we bring those numbers fairly far down to say, well, it's only about a 70% chance that it's going to help you. That's one operation that we could consider, which is, again, it's called a far lateral or intraforaminal discectomy done. I would prefer to do it from a lateral approach rather than an internal approach, and that's one operation we could conceive of. Okay, and the other operation we could conceive of.
Because like right now, I forgot to tell you also, this is hurting me.
Just sitting the way you're sitting.
Now.
Yeah, just
the top of your foot.
Top of my
that's
foot,
consistent with the nerve root.
Top of my foot and also the underneath of my foot.
That's consistent with it. Now, I will say that when you look at where this herniation is on the cross-sectional views, you might be able to
Do you
get.
mind if I sit cross-legged?
You sit and whatever. Watch your phone.
Thanks,
Whatever's more comfortable for you. So the other way you could try to get at it would be from, inside, working underneath the nerve root this way, but it's still in somewhat of an awkward place to get at and to reliably get that nerve root free. So, but those are the two approaches, to try to either use a tubular retractor, remove some of the lateral aspect of the joint, or a more standard bladed retractor and work from the inside and try to get at it this way. Now,
there's no other way.
Yes, there is. So there is another way, and that in fact might be more reliable and wouldn't require as much manipulation of the nerve root, but now it requires a fusion. The other way to do it is actually to come in from the front, okay? Well, two ways really, both including a fusion. One way would be to say, okay, we're going to remove the entirety of this joint, which gives us a lot more access to that disc herniation, because now we've removed the whole joint. We're not working to try to preserve enough of the joint to maintain stability. We just accept the fact that we have to take the joint off, and then we could lift the nerve root up and enter the disc space from the back and do the fusion by passing fusion products into the disc space from the back, and then we use rods and screws. And again, we can use a minimally invasive approach to doing that using a special kind of screw and rod based retractor to minimize the muscle dissection required to get at this joint, to get at the nerve root and do the fusion. It's called a minimally invasive transforaminal lumbar interbody fusion. And again, I'm going to give you a paper to take home with you in between what I just recorded for you and that paper. You can kind of make sense of it. But it's a fusion. It puts us into a different category of surgeries to do a fusion surgery. My preference actually is, for this kind of problem, if we're going to do a fusion, is actually do the fusion from the front, and because it requires less manipulation of the nerve root. And what we do is we come in, make an abdominal incision. Do you have any history for any abdominal incisions?
Yeah, you had surgery.
Oh, yeah, I had a tummy tuck.
Okay, a tummy tuck, but no other surgeries on your abdominal wall, right? So that's all superficial to the muscle.
The only surgeries I've ever had has been for fun.
Okay.
How did you deliver Mickey?
Okay.
Oh, come on.
What?
Yeah.
Of course, I have babies.
Cesarean section?
No.
Transvaginally.
Yes.
Okay.
Okay.
So
Gotta make sure it's
so we could put an incision on the abdomen. Sometimes we'll use that transverse incision from your abdominoplasty, and then lift the skin up, and then underneath the skin inside the abdominal wall. We don't cut any muscle. We work between the two rectus muscles on the front of the abdomen, and then we sweep the intestinal sac out of the way and work between the major vessels on the front of the spine to cut the disc herniation out from the front, and it allows us to spread the bones apart, take the disc out, and we can take the disc herniation off the nerve root without manipulating the nerve root to get underneath it. We're working from the front to take it out. So we can do the discectomy from the front, and I've done that operation for lots of patients with disc herniation similar to yours. If not as the index procedure, then as a salvage procedure, to where let's say the first discectomy didn't provide the kind of relief that the patient wanted and needed, we come back at a second sitting and we'll take this disc out. So we take the disc herniation out, and then we've got to fill it with something. And what we do is we put some type of grafting material in. It's often a plastic cage with bone graft inside it, or a cadaver bone with some bone grafting stuff inside it. Mm-hmm. Put a little metal plate and screws on the front, close, turn the patient over, and then under x-ray guidance through 2 small incisions, we place rods and screws without doing any muscle dissection on the back of the spinal column.
Do you still have the same flexibility?
You'll lose a little bit, but not to the degree that you'd actually realize that.
I mean, like right now, I can put my hands on the floor.
I think you still would be able to. I don't think it would impair your flexibility substantially, but it does transfer stress to the disc spaces above, and that's where the problem of doing a fusion comes, is that it's not a natural condition to have your spine not moving at that level, and there's a stress transfer to the level above, and that stress transfer can accelerate the pace of degeneration of that other level, and then you can run into trouble so it's really important, if you're going to do a fusion, you want to leave as much of the supportive structures on the back of the spinal column as intact as you can, which is why we do it the way we do it these days. In the past, a fusion would be done by making a midline incision reflecting the muscles to the right and the left. We did a lot of collateral damage in order to get where we wanted to get. Well, we don't have to do fusions in that destructive of a manner anymore. We can do it in a much less invasive way, as I said, using a minimally invasive retractor to get at this joint, put our screws in, x-ray guidance to put our screws in over here if we were going to do it all from the back, or do it from the front and back approach. So really there are lots of operation that we could consider. I will tell you, the one that would be most definitive and easiest on your nerve root would be to do the fusion from the front and from the back, because that doesn't require much in the way of nerve root manipulation. All of the other surgeries that we talked about, either the discectomy from in to out or out to in, do require some amount of nerve root manipulation to move the nerve root out of the way and to get at the disc herniation underlying the nerve root. And the problem is that can stir up what is already a very sensitive section, part of that nerve, the dorsal root ganglia, and cause some additional symptoms. That's the downside. Hence, 70% chance if we do that, making you better, rather than the 90 to 95% chance of a standard microdiscectomy.
Because I have had